So osteoarthritis unmasked. Okay, so here are my disclosure. So you know who is paying for that research and what we are doing with the outcome of the research. Here we go. So a little bit of background about what is osteoarthritis. Okay, so most of you understand that osteoarthritis affects knee joint, hip joint, a different type of joint, but it's also affect underlying bones and also skeletal muscles. So it's a very complex disease, okay? Instead of rheumatoid arthritis, where you have only an effect on targeting the joint itself with a lot of inflammation, okay? There's not a lot of inflammation in OA, a lot of pain, very complex to understand the etiology and how it progresses. In terms of progression, there's limited tools available, okay? You can use X-rays, and this is an example in the bottom, so here, so you see what we call the X-rays score, Kellgren-Lawrence scoring, but this is good for only 30% of patients. So you capture about 30% of the patient, and you may have people that not having a lot of pain, not functional at all, and they don't see any sign. If you do X-rays, their knee joint will look almost normal, okay? So that creates a lot of ambiguities about how we study and how can we predict who will progress. But obviously, the end stage of the disease, you are what we call bone on bone. It's a lot of pain. Secondly, there are two types of osteoarthritis. You have secondary arthritis, so if you have an obese person, you will have biomechanical and minor trauma, or if you use overuse of your joint because you work as a tennisman, for instance, or you work in construction, okay, you overuse some of your knee joint or some of your joints, and that will also predispose you to develop what we call a secondary osteoarthritis. The most important cause is the primary osteoarthritis, the one that an individual is genetically predisposed. So OA, or osteoarthritis, is the most common form of arthritis and leading cause of chronic disability in the world. Today, 1 person in 9 will develop osteoarthritis. So normally I start to counting and point you, so you will develop osteoarthritis. Rheumatoid arthritis is 1 in 100, but a lot of more research and molecules have been developed in RA than OA. It's a bit surprising if you think about the prevalence and incidence. But because OA is very difficult to capture the etiopathomechanism, that's why a lot of people in the field of inflammation, in the field of immunity, were interested about RA instead of OA. OA is only diagnosed when clinical symptoms appear. You will see your GPs, and after that, when you have problems with regular drugs, you will see a rheumatologist, and you end up with the hand of an orthopedist at some point. So you seek the advice too late because the disease is a very advanced degenerative process, and obviously because we don't know who will progress, it's very difficult to develop a disease-modifying drug. Very prevalent disease, 750 new cases per year that are diagnosed, so probably about 1 million new people every year. So huge market, almost untouched because there is no disease-modifying drugs. We cannot predict. So we are closer in 2015, about 100 million of people, 25 and up. Okay, these are in the 7 top major market, okay, in Europe. And if you go just in, for instance, in India, they have more than 100 million of people suffering of OA. So why do we need biomarker for osteoarthritis? Obviously, for early diagnosis, better staging the disease so you can adopt lifestyle changement, better drugs to pinpoint what are your needs at that stages. Obviously, it's a very heterogeneous population, so we need to identify those subpopulation, develop predictive marker to assess the risk of disease progression, eventually monitoring response to treatment, and validate those disease modifiers. So 16 years ago, we identified a transcription factor called PTX, that stands for pituitary transcription factor, that is involved during development in pituitary gland development, but also in some craniofacial, like the first branchial arch that will give rise to the mandible, the stomatium that will line up the esophagus and stomachal and intestine, as well as the lower limb. On this immunochemistry picture here, you see a femur at 13.5 embryonic day, where you see a proximal distal gradient, so stronger at the proximal part of the femurs and going down. And if you do a full inactivation and knockout of PTX1, this is newborn are not viable, and you have obviously severe craniofacial development defect, as well as the lower limb, while the upper limbs are not affected. Interestingly enough, the heterozygous mice are perfectly healthy at birth, but develop all the changes associated with spontaneous osteoarthritis. So in 2007, we studied them, and we published a paper showing that PTX1 was repressed in OA articular chondrocyte. You see a classical RT-PCR, as well as the protein level, you see a disappearance of PTX1 protein in the articular chondrocyte. So we further investigated what was the mechanism that underlying this repression or disappearance of PTX1 expression. And we identify a region in the distal promoter of PTX1 that encode for a E2F-like promoter region. We use that part to do a DNA pull down, and we couple that with mass spec spectroscopy, and we identify prohibitin. Prohibitin is a molecule for almost all seasons. It's a mitochondrial molecules, and that play a role in the crystal morphogenesis and function of mitochondria, but is also associated with different forms of cancer. So breast cancer, prostate cancer, there is an upregulation, and you can see more circulating prohibitin. Also associated with aging and senescence as well. And this molecule is circulating between the mitochondria and the nucleus, but is rapidly exported out of the mitochondria of the nucleus and can go back in the mitochondria, but also through lipid raft can go at the membrane and act as a receptor for different viruses as well. Chikungunya viruses, dengue fever viruses. So a lot of research are going on at that time. So we identified that in osteoarthritis chondrocyte, we see upregulation of aberrant trapping of prohibitin in the nuclei of articular chondrocyte. This is a classical histochemistry on cartilage section, as well as by deriving the primary articular chondrocyte, you see the accumulation here, while this is a normal expression in the mitochondria. TAM20 is a marker for the mitochondria. Interestingly enough, if you do some cell fractionation, obviously you will see an accumulation of, in the nucleus, fraction of prohibitin. You still detect a little in controlled cell, and interestingly enough for us, there is no accumulation in rheumatoid arthritis patients. So what we believe is happening is clearly that we are depleting the mitochondria in a way, and it is an aberrant nuclear accumulation in different cell types, so including articular chondrocyte, which form a complex that repress the expression of PTX1. This has been published in arthritis rheumatology. So by depleting the mitochondria, you have less functional mitochondria. So you raise the paradigm that you are probably healthy in your young 20-something, but you start to develop some overweight, and eventually you be frank obese if you don't pay attention, because your mitochondria are less functional. They are not burning fat as they should, as opposed to secondary osteoarthritis, where you have a morbid obesity due to some other endocrine conditions, and you create some minor trauma. So obviously what we're expecting from a biomarker is that you will be able to detect who will develop OA in a symptomatic population, and among the symptomatic ones, who will progress. You want to look for, identify fast progressor. Unfortunately, all the imaging techniques, you are end up with X-rays, you capture about 30% if you are lucky. With MRI, even with sophisticated now system, about 50% in the best scenario, but you are still what I refer to the irreversible lesion or late stage. If you want to test those patients for any drugs, you will fail. You want to test and detect a subpopulation at risk of rapid progression before that. So that's why we pushed the envelope a little bit, and we looked, because we knew that we have this accumulation, nuclear accumulation prohibitin in osteoblasts and articular chondrocyte, and we look also in the blood cell because those primary OA patients are genetically predisposed. And because PHB1 or prohibitin is expressed everywhere, the same thing should happen in the blood cells. So those are peripheral blood mononuclear cells. You see a normal control. You hardly detect PHB1. And you can we developed a proprietary algorithm so you can determine the number of cells negative versus number of cells of positive for PHB1. But also you can measure by the pixels, you can measure the size and the number of what we call aggregates of PHB1 trapped in the nuclei. So what we are doing with that, this is a real cases. So obviously this is a 52 years females without a family history. You hardly detect PHB1, where you see surgical cases, very advanced, 55 years. So very few cells are negative, and you see a strong accumulation of aggregates amongst each cell. And this is an asymptomatic lady in the middle, 51 years old, without that OA family history, and she will develop scoliosis, not scoliosis, but osteoarthritis, because you see that she's going toward that situation. But we may detect it several years before the first clinical symptoms. Same strategy, so if you don't like imaging system, okay, you can do classical laboratory work with Western blot by fractionation. Again, this is highly specific. It's not associated with aging because we have a very old non-OA patients that are not accumulating PHB1. And obviously, is very specific for osteoarthritis as opposed to mini markers that claims to be specific for OA, but are also present in rheumatoid arthritis or lupus and other things that are more inclined to be associated with inflammation. So what we are doing right now is obviously if you do a number of cells positive in this diagram and the number of cluster of aggregate per nucleus, you will see easily that in that subgroup on your right, there's a fast OA progressor. Those are individuals at risk of severe progression, and that's the one that interests the pharma industry. If you can have a stratification of individuals having that, even though that their clinical symptoms are very minor, you will may validate any disease-modifying drug, as opposed to it here. And you might say that why there's healthy also overlap with OA, because aging people, even they claim to be healthy. It's so common OA that you will capture here some of them, and only time will tell you if indeed they will develop OA. Interestingly enough, and as you may know, there are several animal models for osteoarthritis, and we can debate for the whole day about their relevance or not. But we use the STI or T mice because they develop spontaneous OA. And interestingly enough, you see a normal mice, you see a healthy cartilage with a lot of safran and O in the proteoglycan contents, a lot of PTX1 and very few nuclear PHB1, but you see in OA a loss of proteoglycan, a loss of PTX1, and an increased accumulation of PHB1. In the B panel, you see the correlation of the number of positive cells over time, and the little square here represent a C57 black cis representative index value for the qPCR. So you see that even those strains, which is prone to develop OA, do not accumulate PHB1 as the STI or T, and there is a relative, a nice correlation between the accumulation of nuclear PHB1 in those animals and the repression of PTX1. So now, proving that STRT is a relevant clinical animal model that mimic what is happening in humans, we are right now developing molecules that target the mechanisms that is responsible for the aberrant nuclear accumulation of PHB1. And I won't tell you the real name of the molecule, but as you can see, untreated mice, and those are the beautiful STRT mice, okay? They are real mice, they are not Kobe, they are big, they develop obesity because their mitochondria are not working very well, and they end up on bone. There is no cartilage. If you treat them, we maintain them with prevent the narrowing of the joint space. So in summary, we think that we identify a breakthrough solution for early OA detection before the first symptom. The fact that we use blood cells, okay, we can use many technological platforms, okay, like the Ventana platform that you can do numeric assessment quick, instead to do a different way to do that. So very compatible with existing platforms. Huge global market, okay, a lot of unmet needs, and is not competitive as other in vitro diagnostic assays, such that targeting cancer and infectious disease, at least at this stage, but obviously following the first and second generation of tests, there will be additional competitor on the field. And I hope that I convince you that PHB1 is not only a specific OA biomarker, but also a druggable target. At the end, I would like to acknowledge the contribution of very gifted students. So Cynthia Picard and Martin Pilicelli were the cornerstone of this discovery, and now they are doing postdoctoral training in different institutions. Dr. Jean-François Lavoie, so he fall in love with the business side, so he's in the dark side of the research now, working with Biomomentum, a biotech in Quebec, still on OA. Mr. Sadala Bouanik, who is my research assistant and mouse manager, so without him we won't be here today, as well as Lauriane Bernard, who work on the regulation of PTX1 in different contexts, and my close collaborator, Dr. Patrick Lavigne, who is the orthopedist that provide us the material. Thank you very much.